everyone. Welcome back to the Push Podcast. This is season 2. We are so excited.
Season 2.
I can't believe it. I cannot believe it. So for those of you who listened to all of season 1, we wanted to say thank you. We have loved hearing all the feedback from you guys and interacting with you across our social media platforms. But for those of you who are new, we are going to, reintroduce ourselves and talk a little bit about what the Push Podcast is about so that hopefully you stick around for the rest of season 2. So Meg, why don't you start introducing yourself?
This feels like such a throw off from our usual flow, Sid. Usually Sydney starts us off with her introduction. But you know what? Season 2, it's a new time, fresh start.
Yeah.
So I'm Dr. Megan. I'm an OBGYN as well as a clinical researcher and academic educator. I also am a not so new mom myself now. That was part of my tagline in season 1, but now as opposed to being on my maternity leave and a baby mom, I'm freshly a toddler mom now. So
Crazy.
What a wild ride that has been, but certainly given me some perspective on the whole pregnancy and postpartum phase in a new light. I also have a subspecialty discipline in minimally invasive and advanced pelvic surgery. And so my day-to-day life is a lot of endometriosis, complex pelvic pathology, big fibroids, adenomyosis, but also with a dash of low-risk obstetrics thrown in as well. Sydney, why don't you introduce yourself? How have our listeners come to know you?
Yes. So hi, everyone. My name's Sydney. I am known online for my birth education with Instagram, TikTok. It started on TikTok, but now I'm Instagram, Facebook, YouTube, everywhere, at nurse_Sydney. And as the name suggests, I am a labor and delivery nurse. I've been a labor and delivery nurse for 6 years now, which is wild. I can't believe that. I know that doesn't sound like a lot, but I feel like I graduated yesterday. So it's wild to me. But I went straight into postpartum and labor and delivery right out of nursing school because I knew that's where I wanted to be, and that's where I will be for the rest of my career. I absolutely love it. So that's been my unique specialty that I've worked in since the very beginning, which has been such a blessing. Honestly, I love every second of it. But I also, I do some education online now, which is fun. I do pregnancy, birth, and postpartum education. And then I throw a little bit of lifestyle content in there as well. And that's, actually something new that I haven't talked about on season 2, because when we started in season 1, I was just getting married actually in August, and we were still living in Toronto in the same spot, but now I'm living in LA. So big jump. I'm in a completely different country, which is crazy.
Sydney is very modest. Sydney's Nurse Sydney business and persona and platform has over 1 million followers between all of her different accounts. So she is the veritable expert, at least in social media and content creation in this particular podcast, at least, given that I am learning all of this on the fly. And thank you to everyone who's been so gentle with me as I try to wade through replies and engage in this space.
You've been a natural
for the first time. Natural, I don't know, but I've tried my very best.
It's hard. And listen, you say I'm modest, but truly I forget sometimes that is how many followers I have. When you say it out loud, I'm like, oh, wow, that is a lot. Because truly, I just see you guys as all my friends online, truly. I post this education, and if some of it resonates to you and helps you, then ultimately, that's all I'm here to do. So, and that's ultimately why we started the Push Podcast too, right? So
it is. Well, and for background as well, for anyone who, again, is just joining us in season 2, just to orient you, I also remember when Sydney was first starting out Nurse Sydney and when Sydney was starting out on the labor and delivery floor, because Sydney and I are actually cousins and have been able to kind of go through this educational process together as we've each gone through the various steps of our training. So that's part of where some of our early conversations have come from.
Yeah. And the hospital that I started working at. So the first place
Mhm.
I got a job at is also where you were working. So we were literally working together.
When Sydney started on labor and delivery, I was chief resident at that particular hospital. And so we really we're starting out into this field as professionals together.
Which is so fun.
We have been having conversations around the dinner table over text message for literally years now about the different online myths and discussions that are happening about obstetrics, about labor and delivery, about gynecology and women's health in general. And that was really the root of the Push podcast. Obviously, we started this podcast to talk about, the basics of these things, but also to get into some of the underlying misconceptions that people may have about their own health and to ultimately provide a reliable, easily digestible source of information for anyone who feels that they are kind of left adrift in the sea of information that's available to us now. Because the truth is, Sydney and I work a lot at the bedside. We're both still actively practicing. But there's only so much time that we have in an office visit or a labor for Sid. And there's oftentimes we feel that we just scratch the surface of a topic with a patient and we wish we could have gone into so much more detail. So this is our attempt to do that with you guys.
Yeah, we were kind of sick of every time we got together, we would chat each other's ears off about all of these things all this change that needs to happen and how much we want to educate and, decrease some of that misinformation online. So we decided, hey, this is the way we're going to do it. So before we jump into today's topic, which I'm so excited about, it's going to be a great episode. I wanted to also briefly reintroduce what the podcast is about, like in terms of the actual name. So the name is the Push Podcast. And, I think a lot of people think that we're only talking about labor and delivery because it has the name push in it, right? So when you push your baby out, obviously, which is partly why we named it that. We love that it has that aspect in there because we're going to be talking about pregnancy, labor and delivery. That's a large component of women's health. But we're also going to be talking about pushing back against the societal standards placed on women and pushing boundaries in women's health as well. So, and women's health, like it spans the entire lifespan. I think a lot of people think, especially when it comes to us talking about birth, we're only talking about a short period of time, but we want to talk about everything from puberty all the way to menopause and beyond, And
absolutely. Well, like Sid said, push is like often attributed to the process of like a delivery, a vaginal delivery. But the truth is as well, number one, not only are we not just talking about obstetrics on this podcast, but not everybody pushes out their baby and not everybody chooses to have a pregnancy or a baby or is able to have a pregnancy or a baby. And so the topic or the concept of like grabbing hold of this term of pushing is not only just about the literal sense, but also about, as Sid said, pushing back up against misinformation. And I think reaffirming and kind of conceptualizing the concept of being pushy. Because as women and as people with gynecologic organs, for too long, we were not given good information. And we did not feel we could push for better counseling, better procedures, and correct care. And so we are taking back the term pushiness. We are taking back the term pushing, and we are reinserting that in a positive light in the Push podcast.
Exactly. And, and today's conversation, it's going to be about TOLAC or VBACs as well, for those of you who haven't heard of it.
Which is certainly something that people feel, and I think rightly so, that they can and should advocate for themselves more with.
Absolutely. I think it fits clearly into that bigger picture of bodily autonomy and informed consent, which I think consent is a huge aspect in women's health too, that I think historically has not been taken seriously. So today we're going to talk about it and we're going to push back and we're going to become pushy together because ultimately I don't think that's a negative thing. I think it is absolutely a positive thing that every woman can have and do and be. So, yeah.
So from two pushy women to hopefully many, let's get into it. So Sid, why don't you tell everybody a little bit about, our topic today?
Yes. So today we're going to be walking through what exactly a TOLAC is. So if you haven't even heard this acronym before and you're confused, we're going to walk you through simple, like exactly what it means. But to give a quick overview, it's basically a trial of labor after having a C-section. And we're going to talk about who it's typically offered to, the risks and the benefits, how it compares to having a traditional planned repeat C-section, and then also how this conversation is approached within the Canadian healthcare system versus other parts of the world, like the US, for example. I know a lot of you guys are US listeners, and we're happy to have you here. But of course, we have only practiced in Canada, so we'll be able to talk about that from a Canadian perspective. But we are always happy to also hear your perspectives as well from different parts of the world. So always comment, share, all that kind of stuff. If you guys haven't followed us on Instagram, it's at the.push.podcast. Same on TikTok. Send us DMs too. We are always happy to listen to them, to answer them, and to bring some of those questions and comments back onto future episodes in the podcast as well.
Yeah. So listen, let's talk more about what is a vaginal birth after cesarean section and what is a trial of labor after cesarean section, or a TOLAC and a VBAC, to use the acronyms.
Yeah.
Super quickly, just as like defining the terms from the outside. Again, a TOLAC, or trial of labor after cesarean, is the process of attempting a vaginal birth after you have had a previous C-section. So TOLAC describes the process. Whereas a VBAC, or a vaginal birth after cesarean section, technically is describing the outcome of that attempt, meaning that you did deliver vaginally. Now, these two terms are often used interchangeably. And I think for the purposes of the podcast, obviously we will stick to kind of the correct terms, but I think it's just important to clarify from the beginning so that we know what we're all talking about, not necessarily to like correct, other creators who have maybe used one or the other. But 100%. I think irrespective of what term we're using, what we have seen online is that a TOLAC is often either framed as the super, super dangerous process and really irresponsible for a parent to undertake, or as completely safe, right? If you just trust the birth process, your body was meant to do this. This is the natural way, right? Yeah. And I think that neither of those framings serves patients very well, right?
No, it's just confusing, right?
No,
it's just completely confusing.
And as is true with so many things in medicine in general, both frames can be true in their own way, but for any particular person, we lose out on, I think, the ability to really exercise our autonomy and our choice if we're not speaking honestly and with nuance about those things, right? It is true that VBAC can be dangerous for some people, right? And it is also true that can be a wonderful experience and something that gives people back a lot, I think, of like autonomy over their body and sometimes even I've seen people say that it has like helped heal some trauma from a difficult delivery the first time around or the last time around in any case.
Yeah. Yeah. All right. So now that we've kind of talked about how it's so polarized online, I want to know what your thoughts are on why it's so controversial.
Yeah, it's interesting that there's so much controversy around it, right?
Yeah.
But I think the root of that question really kind of comes back to what would be the harm in somebody trying for a vaginal delivery after they've had a C-section, and what would be the benefit of achieving one? So let's talk about the harm first. The number one thing that we are worried about if somebody tries to have a labor process after they've already had a C-section is something called uterine rupture. So basically, when somebody's had a C-section, the uterus heals with a scar across it, right? From where we made the incision into that organ in order to deliver your baby. During a trial of labor, the uterus and the uterine muscle has to squeeze really hard and repeatedly to push the baby down. Those are contractions, right?
Yeah.
And that old scar is slightly less stretchy, basically, than the rest of the muscle. Scars in general don't have the same integrity as the original tissue. They will never achieve the same like strength as the tissue before it was cut into. And certainly the uterus is no different with that respect. But the difference, I think, between a uterine scar and a scar anywhere else on your body is that we know that if you undergo a labor, it's going to undergo like way more stress than we would reasonably expect from any other organ system, right? Because labor is inherently really intense.
Yeah.
So basically, in most labors, that uterine scar is going to hold just fine. But if the uterus is working really hard for a long time, especially after a long, difficult labor, or sometimes if there are other factors that perhaps make the uterus or the scar a bit weaker, or sometimes just because of bad luck, that pressure on the weaker spot can cause the scar to separate or tear. And that's what we mean when we say uterine rupture. It's not super common, but it can have really serious consequences for moms and for babies alike, or for parents and babies alike, I should say. And that's why people attempting a vaginal birth after C-section often need to be monitored very closely and counseled, I think, really appropriately about what those risks might be and how the risks might differ for them specifically.
Okay, so as you're talking about the risks, I'm curious as to why someone would choose to do a TOLAC, to actually have that trial of labor after having a C-section. Why would they come to that decision?
That's a really good question. And ultimately, I think, I knocked out my headphone. Ultimately, I think is a question that is really individualized, and every individual pregnant person is going to have kind of different reasons for wanting to try for a vaginal delivery. But I think the first reason that shouldn't be understated is because the overall success rate is actually very high. If you had to guess, Sid, what do you think the success range might be for people undergoing TOLAC? How many TOLACs become VBACs overall, like for all comers?
Okay, I'm going to simply go from my clinical experience. Like how many patients I would say have labored after having a C-section. I would say 40%. Like I actually don't think it's that high.
It's actually
but you're telling me it's higher.
It's so much higher, Sid. It's so much higher. And we have both worked at a lot of like tertiary care centers where we're probably
maybe that's
taking
why.
care
Maybe
of
that's
patients who are more complicated. And so perhaps that's why like your anecdotal experience feels a little bit skewed. But it's actually 75% about in the United States. And depending on the study you're looking at, it ranges from anywhere between 60 to 90%. So number one reason why somebody might try for a vaginal delivery after a C-section is because they're substantially likely to be successful, right?
Wow.
And if having a vaginal delivery was something that you wanted the first time around, a trial of labor after a C-section, one C-section in particular, is super, super reasonable, right? And in fact, for, as an overarching statement, many societies and guidelines recommend like empowering people to select that. Now, what are the like health benefits to a trial of labor after cesarean? I mean, first of all, we know a vaginal delivery comes with a faster recovery and a quicker return to normal activities than undergoing an abdominal surgery, right?
Major surgery.
And again, these are like generalizations. This is obviously, there are people I'm sure who say like, I bounced out of my C-section and felt amazing. And there are people who had really physically trying vaginal deliveries, right? That took them a long time to recover from. These are just kind of like overarching statements as opposed to like individualized ones. There's room for all of that experience. Vaginal deliveries also carry with them a lower risk of infection and reduced risk of blood loss during surgery, as well as reduced risk of requiring a blood transfusion. Obviously, if you have less blood loss, less likely to require a transfusion. There's also less risk of placental complications in future pregnancies. So with increased cesarean sections, we are increasingly capturing this phenomenon called placenta accreta spectrum, whereas basically the placenta starts to grow into the muscle wall of the uterus. That's a far more complicated pregnancy and can be life-threatening for moms and babies in lots of circumstances. And oftentimes for placenta accreta, or placenta percreta rather, which is where it grows into the muscle wall of the uterus, those patients often and typically require a cesarean hysterectomy, which means we deliver your baby and then remove your uterus at the same surgery because we cannot separate the placenta from the muscle wall. So obviously,
which
a much
is
bigger
still not
surgery.
common, right? Like that's still not super common.
It's not super.
I've
common.
only
It's not
seen
like,
one actually.
My bias is that in my fellowship I trained at a PAS
So you've seen
site,
a few, but
so I was on the Percreta team at that hospital and did quite a few of them there. You're right though. They are not super common, but they're on the rise. The incidence is increasing in part because of the increasing incidence of cesarean sections.
Of C-sections. Gotcha.
Yeah, exactly. And there's lower overall surgical morbidity, right? And what that means is that if you don't have a surgery, you're unlikely to have very specific surgical risks happen to you, right? So things like decreased risk of like bowel and bladder injury, right? Because we're not actually operating on your abdomen. Every time we go into your abdomen with a C-section, scarring can happen within the abdomen, and that can make future surgeries much more difficult and complicated. And so decreasing the amount of surgeries on your abdomen certainly is in service of decreasing what we call adhesions or scarring within the belly itself. Yeah. Now, I think we should step back here before we get into too much of the further details of it, because I just want to take a moment to acknowledge, number one, that one of the benefits we haven't talked about here, which is less well described in the literature, is the emotional benefit for some pregnant people of being able to achieve the delivery that they originally envisioned for themselves, right? And that can't be understated. It's intensely personal, and is certainly something that I think many of our patients experience with a successful VBAC. The other 100%. Thing, though, that I want to take a moment to acknowledge is we're going to go through TOLAC and VBAC and talk about all the risks and benefits so that people feel empowered when they make that decision. But it is perfectly reasonable to choose a cesarean section for yourself if you feel that it is in the best interest of your health. And there are innumerable reasons why somebody might choose to schedule an elective cesarean, especially a repeat elective cesarean if they've had one previously. And so the intention of today is just to talk about VBAC in a nuanced way so that it's more easily understandable. It is not to suggest that everyone must choose a VBAC. So if you're sitting here going, you know what, I picked an elective repeat cesarean, and it was perfect, and I loved it, and you know, like I wouldn't go back and try for a VBAC. I'm not here to try to make you feel like you should. That is the best outcome is that you are happy with the information you were provided and with the delivery that you had. That's what we aim for every single patient that comes through our doors.
Yeah, what we're trying to do here is kind of sit in the middle of both, because I think online it's very like we said before, it's very polarized of like VBAC is dangerous and irresponsible, or you should just trust your body and you absolutely shouldn't have, have a repeat C-section. And we're here to just respect your autonomy and stay honest here about the risks and the benefits, and then give you the information you need to make those choices for yourself. That's always what we're trying to do here. We're not here to judge you for anything. And for some people, having a VBAC and being able to experience vaginal birth is something that's very, very important to them. And I think that's okay. I think I'm going to be one of those people, like just truly, just because that's who I am. I know that I'm going to be like that. But saying that, I know there's also people out there who absolutely do not feel that way at all. And that's okay.
That's so fine.
That's okay.
That's so fine.
I've taken care of many patients who do not even want to try labor. And I'm also all for supporting you if that's your decision and that's what gives you like the choice that you want to make. Like it's ultimately your choice.
Even amongst professionals, like Sid and I've talked on offline about how like amongst labor and delivery nurses and OBGYNs and family docs that deliver, like, I think that there is a pretty wide spectrum of people who either would want a like elective first C-section, like they just would like to come in and do a C-section as their primary mode of delivery. And that's great. Like I actually know lots of OBGYNs who have decided that for themselves.
Totally.
And incredible. I also know lots of OBGYNs who are like, die hard, I'm going to have a vaginal delivery. And Sydney and I, in preparation for this episode, had a fun little offline conversation where we were like, what are all of the circumstances in which you would VBAC? Like when, or TOLAC rather, like what would be the circumstances of your first C-section where you would try for a TOLAC?
Yeah.
And we had different answers. We had like pretty close answers, but like they were different
people still. We're different people. We have different desires and but that's why it's so hard to be able to say one thing and it fit for everyone, because that's never going to be the case, right?
No, exactly.
So that's why we're talking about both. And I think a lot of people forget though, that even with a repeat C-section, how amazing it can be.
Oh my God.
Because a lot of times they've experienced trauma from their first delivery
Yeah.
because it was probably not always, but
Yeah.
it could have been a emergency C-section.
Yeah.
And that can be really traumatic, especially if you've already undergone hours of labor and then headed into an emergency C-section. So there are benefits to a scheduled C-section that I think a lot of people forget to actually consider.
Oh my God.
Too.
I have seen a scheduled elective, like an elective repeat C-section be a healing delivery in and of itself for somebody that has had trauma from their previous C-section. To paint the picture, oftentimes, like, especially if you're the first C-section of the day, the first C-section of the day slot is elite. You roll in.
That's the slot
everything
you want,
is running on time. You get your lovely spinal. You have no tube in the back. Your partner is in and
music
around.
if you
We're
want.
like, what music do you want to play? You have a fresh team. Like, it's gorgeous. An elective repeat C-section can be just like such a smooth, wonderful
You know the
procedure.
date and time. You know
I have had so many patients feel so happy and so supported in the context of a scheduled C-section. So suffice to say, like, again, super variable. We've talked ad nauseum about how like it differs based on the person. But Sid, it also differs based on the hospital and based on your region and based on your country, right? Whether like how much a trial of labor after cesarean is supported and in what context it may be offered to you or recommended.
Exactly. So I know that, we've mentioned previously, we're obviously from Canada, but we do want to speak for everyone listening. We want to speak for everywhere in the world. But we've only practiced in Canada. And I know that there's certain protocols that might differ, even just based on hospital, right? So one hospital might have a protocol that, you can have a V or a TOLAC after one C-section, and then another hospital, it might be a different option or protocol. So can you walk us through what most Canadian hospitals actually support when it comes to TOLACs?
For sure. So hospitals are going to differ based on size and resources and staffing, right? But overarchingly, from a national perspective, our regulatory bodies, as well as the regulatory bodies in the US and in comparable healthcare systems, actually recommend, provided there's no reasons why somebody shouldn't or couldn't do this, why it would be, unacceptably high risk, for people who've had one previous transverse, which we'll talk about a little bit later, lower segment cesarean section, so kind of like a standard C-section, they should be offered a trial of labor. After, of course, appropriate discussion of maternal and perinatal risks and benefits, right? So the standard of care in Canada certainly is if you've had one kind of uncomplicated standard issue C-section, you should be offered a trial of labor. And your provider should be able to talk to you about when and how you might choose to do that. Now, Canada as well tends to err towards recommending a cesarean section a trial of labor after cesarean in a hospital setting. And the reason for that is to ensure that timely cesarean section is available for you should you undergo or should you experience a uterine rupture. Basically, that we can very, very quickly move you to the operating room, that we can convert to a C-section, and that we can deliver your baby so that you and baby are safe.
Yeah, because if you're trying to do a home birth, that transfer to hospital and then to the operating room can be very long in certain cases. And from our experience, like minutes matter at that point. It's quick. We need to be quick.
Yeah. Now, part of the reason why the Canadian system recommends this, or some of the factors that might influence this, if you're sitting there from another place in the world and you're saying, "Whoa, like my healthcare providers don't recommend ever doing a trial of labor after cesarean," here are some of the factors that that kind of shape that recommendation in Canada. Number one, Canadians have universal health care, right? Which means that if you're a Canadian citizen or a Canadian resident, you are able to come into any hospital in the country, even no matter your province, and have appropriate care with no additional cost to you, as long as it is a service that is provided for under the Canada Health Act. And certainly obstetrical services are provided under the Canada Health Act. They're considered part of our human rights and our rights as Canadians. Most Canadians also undergo hospital-based births. And we are very fortunate in Canada in that we have integrated midwifery models, where midwifery models exist within hospital systems. So oftentimes people are not necessarily forced to choose between midwifery care and having a trial of labor after cesarean, because many of our midwives and midwife practices have hospital privileges and are able to guide people through processes in hospital itself. Now, I'm of the opinion that we have a lot to learn from some of our similarly structured healthcare systems, like in the UK, for instance, about how to like even more meaningfully integrate midwifery care into obstetrical care. But certainly Canada has a system where that collaborative care is provided for. And the other thing that Canada often has as well is that emergency resources are generally available, right?
Yeah.
Now, this is not true in every single region in Canada, obviously. And Sydney and I both have had the immense privilege of practicing in a major city where we have tons of resources available to us at any given moment. So in Canada, access to trial of labor at cesarean isn't really about things like insurance, which might be a concern in the US, but rather about things like institutional comfort, staffing, right? Do you have an anesthesiologist that is available quickly? How big is your hospital setting? How many nurses do you have? And is, your obstetrical provider, your midwifery provider, are they in-house? So, staying in hospital at all times, or are they at home?
So as you're talking about that, I also want to make it clear that it's, all these systems and the differences and all that kind of stuff. It's not about denying choice either.
No.
I think it's about making sure a system can respond safely if something actually does go wrong.
For sure.
So I want to put that out there because I think a lot of people start to blame the system, which, listen, there's always improvements that can be made. But at the end of the day, we're just trying to operate at a safe pace. And ultimately, having a TOLAC or a VBAC, you are at a higher risk of things happening. So the system needs to be prepared for that, right?
Yeah, exactly. As with so many factors about this, like your choice to do a TOLAC or an elective C-section varies based on your institution too, right? Like there are communities in Canada and in the United States where there is 1 or 2 or 4 OBGYNs available on labor and delivery at any given moment, and multiple anesthetists. Several of our hospitals have anesthesia services available just for obstetrics overnight and during the daytime. Whereas on the complete other end of the spectrum, there are communities that, have 1 OBGYN available to them, period, right? And that person is at home because the deliveries are happening so much less frequently, right?
Exactly.
There are communities in our own country that have no OBGYN, right?
That
have deliveries provided for only by family doctors and by midwives who provide excellent care, but are not ultimately surgeons, right? And it may be general surgeons who are doing the cesarean sections. There are communities that have no providers, right? And people laboring in those environments are either provided for by traditional health models or have to leave home in order to access care for their deliveries themselves. And so obviously the risk in that worst case scenario of, harm to you, harm to your child varies depending on what type of site you're at, right?
Yeah, exactly. And just to move on from that topic, I want to know, when you're counseling patients about TOLAC versus having a planned C-section, what are the risks that you talk about for TOLAC specifically? Because I know we've gone over what the risks are for a repeat C-section, but you can get into that as well. I want to know, what are the things that you counsel your patients on?
Yeah. I mean, I think the crux of this discussion that just to cut to the chase a little bit with it, right, is what's the risk of rupture, right?
Yeah.
Because if I tell somebody that the risk of rupture is 98%, they're going to say, hell no, I'm not doing that, right? For the most part, right? But if I tell them that it is much lower, then it's something that is much more considerable, right? So with 1 prior low transverse cesarean section, so again, a horizontal cesarean section, and I mean, by that I mean on the uterus, not necessarily on the skin.
I'll put a picture on screen for those of you who are following on YouTube, just so you can see where the actual incision is. But
what a low transverse or phalansteal incision is. The risk of rupture is about 0.5 to 0.7%. So about 0.5%, or about 1 in 200 women. Now, this is a 3 times higher risk than if a planned cesarean section was undertaken, but it still is a fairly rare event, right? The vast majority of people who undergo a trial of labor after cesarean will not have a uterine rupture. I think that is important to consider. Like, it's always important to consider what the actual numbers are, because for some people, again, some people say any risk is too much for me, right? And that is totally fine in their prerogative. And for other people, they say, you know what, the emotional risk to me of undergoing a repeat C-section or the complications of C-section, right? For which many of them are greater risks than 1%, is the bigger consideration. And that's something that there's no universal formula that tells you what the right answer for that is, right? Yeah. It's all about like risk tolerance, right? And what particular complications are concerning for some people versus others, right?
Yes.
Trial of labor after cesarean, for what it's worth, also does carry with it a higher risk of endometritis, so infection within the uterus. So it's again about twice as much as with a normal vaginal delivery, as well as, again, blood transfusion. And now this is not compared actually to cesarean sections. It's compared to vaginal deliveries when a C-section has not been previously undertaken. So it is a bit of a riskier vaginal delivery in many ways than one in which the uterus has not previously been scarred. Okay?
Yeah.
But here's the thing. Labor doesn't happen in a bubble, right? And even with that 0.5%, there are people who are at higher risk of having a rupture or at lower risk of having a rupture, right?
Yes.
And so there are a variety of different things that weigh into, whether somebody is encouraged or offered to have a trial of labor after cesarean, or whether they are counseled that the risk may be unacceptably high for their individual circumstances.
Right. And I know something like the incision, which is what we mentioned before, but if it's a lower transverse incision versus a horizontal or a T incision. So there's all these different things that you'll need to actually find out from your previous C-section what was done, because that ultimately will decide how high of a risk you are for uterine rupture during labor.
Yeah, exactly. So as Sydney mentioned, and as we've kind of like alluded to, there are a variety of different places that we can make an incision on the uterus that would allow us to take out your baby, right? I'm going to put my hand up here. Like, I'm kind of like imagining these images popping up. Apologies if you're listening to us on the podcast and not on YouTube, where you can see these images in real time. But the first and most common in modern days anyway is a low transverse incision, right? So this is placed on the lower aspect of the uterus, kind of horizontally. And what's nice about that one, what makes it kind of an ideal position if someone is going to undergo a labor in the future, is that lower uterine segment undergoes less mechanical stress during labor compared to other areas of the uterus. Yeah. Now, other ways that we can make an incision in the uterus are up and down, which would be a classical cesarean section. And sometimes we make a T-shaped incision as well. So somebody may start with a side-to-side incision, and then if we're unable to remove the baby that way, we may make an additional incision upwards from that T. Now, I think, the reasons why we might choose a classical cesarean section or a T incision, it's a little bit outside of the scope of this discussion today. But what I want to reassure people, especially if you've had one of those things, is that there are absolutely indications for both of those approaches to cesarean section. And so I don't want anybody to think just because we're saying that that's not the best incision for a trial of labor afterwards, that means that something was inappropriately done for you. Chances are that was the best and safest way to deliver your baby.
Very good point. Yeah, it's not something that you would go out of your way to do unless it was absolutely necessary. And that's the same with every other provider.
And again, the standard of care in Canada, unless there are indications otherwise, for which there's many, the standard of care would be a low transverse incision. The classical and T-shaped incisions, depending on the study you're looking at, carry a rupture risk as high as 4 to 9%. Not 49, 429 for anyone. Sorry, who may have misheard me, because I realized as I said that I kind of slurred it together. But that's still, is quite a high risk of rupture.
Higher than 0.5 for sure.
Certainly higher than 0.5.
Yeah.
Now, a common thing that we get asked a lot about is, because I think we've referenced before, like that this is a good option for somebody who's had one prior cesarean section. But what if you've had two prior cesarean sections? Have you seen this, Sydney?
Yes. So this is something I think that is coming up a lot more online too, is if, some people have had two C-sections and then they've realized after that they would really like to try for a VBAC. And I know like the risk can change with subsequent surgeries. How do you help patients navigate that decision-making process? And what do you offer your patients who have had two previous C-sections and would like to labor?
I mean, listen, again, the caveats to this are that there are individual factors for every single person that extend even beyond the number of C-sections they've had, right? And those things may influence how likely somebody is to have a vaginal delivery after C-section and how risky undertaking a labor would be for that person, right? Similarly, like institutions have different policies and availability of emergency services. And so it could be that in some places, the additional risk of a second cesarean section kind of exceeds the capacity of that facility to be able to respond appropriately.
Yeah.
Overarchingly, we do know that the risk is higher with two C-sections for uterine rupture than for one C-section. So the risk that we're looking for tends to about double, depending on the study, with two C-sections. 2 to 3 times higher, depending on what you're looking at. Now, again, that means we're looking at like a 1% or 1.5% or 2%, depending on the comparative study, risk of uterine rupture, which is still not a giant number, but it certainly is higher than with one cesarean section, right? We know that scar is weaker after two incisions.
Yeah, and when we're saying weaker, it's also the tissue is thinner. Like I feel like that's a good visualization for people, is that it just gets thinner, right? Like if you multiple times cut through the same spot, it's going to be thinner. And then when you add labor on top of that, and the uterus is squeezing every couple minutes for hours on end, the chance of it rupturing and opening up are going to be higher. It's that simple, right?
Yeah. And I should say as well, I feel like, because this sounds like such like a crazy thing to happen, I'm sure it's kind of implied, but I realize I didn't mention from the outset too that it's very dangerous for baby to be inside of a uterus that has a uterine rupture. And the easiest way to kind of explain it is that we worry that the oxygen supply to baby is being cut off, because the placenta, which is the organ that connects baby to mom and baby's blood supply to mom's blood supply, is invariably disrupted. And bleeding begins from the uterus, and we worry about like major consequences to baby with kind of that acute change in the environment. And so I think what's important to note is that the success rates between somebody who's had one prior C-section and two prior C-sections are pretty comparable. It's a little bit less likely to be successful with two, but not dramatically so. The difference, depending on the study you look at, there's a study of a tertiary care center, so a major center, many women, that basically found that the one-time C-section group had a success rate of 79%, and the two-time C-section group had a success rate of 74%. So again, like a statistically significant drop, but not dramatic, right? Some other factors that might impact somebody's likelihood of having a success, or their like candidacy, I guess, for a trial of labor, would be whether they've had a vaginal birth before. We often think about this as like kind of the second child that somebody's had, but it's also not uncommon for somebody to have had a vaginal delivery or several vaginal deliveries and then have a pregnancy or a labor that kind of throws everything for a loop and requires a C-section.
Totally.
In spite of the fact that we know that they have been able to have a successful vaginal delivery in the past. So it makes a lot of sense that a history of a prior vaginal delivery is the single strongest predictor for a successful VBAC. And so for people who've had one prior vaginal delivery prior to their C-section, the success rates are more like 85 to 90%, as opposed to about 60 to 70% for people who have not had a prior vaginal birth.
Yeah. And I think this kind of brings in the conversation of what happened during your last delivery?
Exactly.
Right?
Indication for the first C-section. Yeah.
Yeah, that's a huge part. At least for me, if I was making the decision for myself, and
Mm-hmm.
I'm sure with you as you counsel your patients as well, it's a huge part of the decision-making process. Was it, an emergency C-section? At what stage of labor were you
Mm-hmm.
at? Were you
Yeah.
pushing? Were you, was it a fetal heart rate abnormality? So was it baby's heart rate that dropped and you
Mm-hmm.
immediately had to go to surgery? Or was it, your cervix? Your cervix wasn't dilating for some reason. Was it the baby's positioning? There's so many questions that you can go through with your provider that will be all listed in your history on your chart from your previous delivery that can help guide you on whether or not you might want to try it again.
Yeah.
Basically.
In general, we kind of think about these indications as being either like non-reoccurring indications or potentially reoccurring indications, right? So if something happened during your labor where suddenly our monitoring of baby showed that baby was in distress during labor, that can happen for lots of reasons outside of just like, are we physically able to push out this baby or not? And so we consider that, for instance, to be a non-reoccurring or potentially non-reoccurring indication. Similarly, like a classic one is breech position, right? And although there are certainly like physiologic factors that can make a baby more likely to sit, or babies in general more likely to sit in breech, sometimes babies are just randomly breech or bum down.
Yeah.
And so if you had a C-section for breech with one baby, and then your next baby is head down, that would be considered to be actually a factor that would lie in your favor for having a vaginal birth after cesarean section. Whereas,
100%.
as Sydney said, if it was that our cervix just wouldn't dilate to full dilatation, or you pushed and pushed and pushed and just weren't able to deliver your baby, those would be factors that we would consider to be potentially reoccurring if it's more about baby's ability to fit through this particular pelvis or not. And those lend for a little bit of a decrease in the success rate of a C-section, or of a vaginal delivery, rather. Now, that doesn't mean that we tell people who have had C-sections for those reasons that they shouldn't labor, right?
Yeah, not at all.
And
not at all.
Outside of individual considerations, right? So if your physician told you after your particular C-section that they don't think it would be safe for you to have a vaginal delivery again, that's one thing. But it's a thing to think about. It's something that might decrease the likelihood of success, but not a contraindication to a trial of labor after cesarean.
Yeah. And I just want people to know, I think a lot of times people think, oh, well, I've had a C-section. I guess I just have to have a C-section again. And I just want people to know that that's not necessarily the case. There's options. There's so many options. And, if you don't want to explore those options and you want to just have a C-section, again, that's also totally fine. But, listen to your provider. If they've said, hey, I don't think it's a good idea, there's probably a reason. And you have the right to ask the questions as to why they feel that way. Maybe it is something to do with the way the incision was made in the C-section, which makes the risks higher, as we've discussed. So there's lots of reasons. I know some other experiences I've had with patients who have had a C-section and then a VBAC after is like the fetal heart rate getting really high due to an infection during labor. Sometimes that happens, and there's nothing we can really do about that other than give medications, and sometimes those don't work. So you need to have an emergency C-section. And then my patients have come back and with subsequent pregnancies had a beautiful VBAC. So it's there's lots of different things to consider here, and I think it's impossible to go over every single situation in one podcast episode. But I hope that's able to give you a little bit of an idea of all of the things we're thinking about as your providers as we make this decision with you. Okay, so Megan, a lot of my patients ask me if I want to try for a VBAC or if I want a TOLAC after having a C-section, how long do I have to wait before I get pregnant again?
That's a great question. And people ask us this all the time. And I mean, let me say as well, the short answer is if you get pregnant before the timeframes we're going to discuss, we will talk to you. We will take care of you no matter what, right?
100%.
If you decide to do a trial of labor, with a short interpregnancy interval, that's ultimately your prerogative, right? And your provider's responsibility really is to make sure that we have accurately and truthfully counseled you about what the risks may be so that you can make the decision that's best for you. I want to like frame that from the beginning because I have so many patients feel so like stressed about what if I got pregnant and what would happen in that case.
Exactly. Yeah.
But in general, we do recommend if you've had a C-section, especially if you definitely know you want to have a trial of labor for your next delivery, that we wait at least 18 to 24 months between pregnancies. So that's called an interpregnancy interval. And what that actually means is 18 to 24 months between your delivery of the C-section to the start of your next pregnancy. So not from like delivery to delivery. Okay. And the reason for that is that when the uterine scar has less time to heal, we know that the risk of rupture can be elevated. And again, that can be up to like 1.5 to 2 times higher risk of rupture than if we just gave the uterus a few more months to heal.
Yeah.
So listen, short interpregnancy interval is not an absolute contraindication to a trial of labor after cesarean.
Yeah.
But it's just one factor. All of these things are like one factor among many factors that would shape the counseling that we would give somebody, right? If somebody's had one prior C-section, was a great candidate for TOLAC otherwise, and had an interpregnancy interval that was like 14 months, well, my counseling for that person may be, a lot more favorable even than somebody who had like several C-sections or a classical incision and all these factors that kind of lent towards either, not decreasing the likelihood of a vaginal delivery or increasing the risk of a rupture, right? So it's one factor among many things that we consider as we're kind of talking about what the risks and benefits may be here.
Yeah. So
now,
a good question to ask though, like 100% something that needs to be considered but talk to your provider in this case.
Oh, I would honestly say that's like the number one question I get for people who are considering, like who have had a C-section, they knew they wanted a vaginal delivery and they know at the outset they're going to have another pregnancy and they want a vaginal delivery the next time.
Yeah.
For those patients, like the first thing they ask me at a postpartum visit is, when can I get pregnant again? Like how long do I have to wait?
Right. And what is your answer? Like, what do you say? Do you always say the exact same thing? Like, how do you respond to that?
Honestly, exactly as I just did, right?
Yeah.
Like our best recommendation is going to be to give that uterus at least 18 months time to heal, right? Because we know that that's kind of the time that organ needs to gather as much of its like structural integrity as it can so that we're like putting it in the position where it is the absolute strongest it can be before we test that scar again with a labor, right?
Totally. That makes sense.
But again, that's one factor also among many that people might consider in their lives, right? And sometimes for some people, waiting 18 months to get pregnant again is unacceptable for other reasons, right? Yep. We all have a like rich internal life and a variety of different factors that weigh into how high or low risk we are, right? That's why so many things in medicine are not super clear cut, but rather incredibly nuanced and should be individualized to the person that's in front of us.
Yeah. Yeah.
Now, something that we can't kind of change or prevent is our age. Yeah. And unfortunately, women who are older do have a lower success rate of a vaginal delivery after C-section than women that are younger. And the age where that decrease in success starts to creep up a little bit is around 35 to 40 years old. Okay. Now, again, we do not counsel people. It is not a contraindication to a trial of labor if you're within that 35 to 40 year or older age group. But something to consider, something to weigh, in our minds as we're each individually kind of thinking about, what mode of delivery, what feels right to me moving forward, and planning for the delivery of my child.
100%.
Now,
that's a good thing to note.
Similarly, there are some characteristics of like the labor in the current pregnancy itself. So not the one in the past in which you had the C-section, but the current pregnancy that also can kind of dictate how likely this is to be successful and also what the risk of rupture, right, may be.
Yeah.
And the first and most like important one really is whether somebody goes into spontaneous labor on their own or whether they require an induction. And the choice to induce for a patient that we know is going to try for a labor after cesarean is always one that is like weighed very carefully.
Yeah.
And the reason for that is because induction in and of itself, thanks to many of the methods that we use to start contractions, also increases the risk of rupture. And overall for induction, that risk of rupture is about 2 times higher, a little above 2 times higher than it would be if no induction was used.
Yeah.
So again, that's nothing to discount.
Yeah.
We at the Push podcast, and certainly me as a personal human, are big fans of induction of labor, or at least like big fans of induction when used appropriately, when like patients are counseled well, and when that's the best method moving forward to deliver a baby. But it does carry that risk in this particular context.
And that's why I know some patients who have, on their charts, if to go into labor, will attempt a VBAC or will TOLAC. But if they don't go into labor on their own, then they will have a repeat C-section, and they'll have that date actually booked for that C-section.
You are totally right, Sid. And thank you for bringing that up, because I actually feel like not enough people know that is that's an option, right? You can say like, listen, like I don't want to go past my due date. I don't want to have a baby that grows too big, because both of those things, certainly large for gestational age infants, again, also associated with failure of I don't want to say failure. Failure is like a really hard term, but like a trial of labor ending in a cesarean, right? As opposed to a vaginal delivery. And it is, and gestational age, so how far along you are in the pregnancy, and particularly if you go past your due date, there are studies that also show that is a strong predictor for a trial of labor that ends in a cesarean instead of a vaginal delivery. So again, these are also things we weigh when we're thinking about like, do we induce or not, for instance, right?
Yes.
But a lot of people don't know that. Like you can say, listen, I don't want to go past my due date. I don't want to like run that risk or have those risks elevate.
Yeah.
But if I go into labor before my scheduled C-section, then let's give it a shot. Let's
try.
Do it. Yeah. I actually on call have admitted lots of patients, and usually kind of take that opportunity to have a new discussion with somebody. If they're coming in and they've had one prior cesarean before and they go into labor on their own, and it seems as though that early labor is progressing really nicely.
Yeah.
Sometimes that's also an opportunity to talk to somebody and say, hey, like, listen, did you talk about trial of labor with your provider? Is this something that's ever crossed your mind? Is there any part of you that's thinking perhaps you want to give it a try now? And if the answer is no, incredible. We'll do a lovely cesarean section for that person just a little sooner than they planned.
Yeah.
And if the answer is, actually, I want to go for it, then what an opportunity to, again, talk about the risks and benefits, make sure that they're informed, and then as a team, work through a labor process.
Yeah, exactly. I actually kind of love when I hear OBs having that conversation with the patient, because it's just, to me, it's again, giving the patient that control, because ultimately they have the decision. Like if their body went into labor and they don't want to continue labor, they can have a C-section. But if they want to try, it's also a perfect opportunity to try. So I love too,
for any, especially our Canadians that are listening, as a Canadian provider, there is like I love when I get a little message or a little delivery summary or a note for a patient that I had a C-section booked, but I knew they were hoping to go into their own labor beforehand, and I see that they rolled in their own labor and we get to cancel the section. I'm like so happy for that person.
Oh,
That's like one of my favorite delivery summaries to get.
Yeah, it's so fun when we have to X off the scheduled C-section, honestly. We're used to it, guys. It happens.
Honestly, like no one should have any fear that we as providers are like, oh, I was really hoping to do that section. Like, we're happy for you. Like,
it will get filled with someone else. I'll tell you that much.
Oh yeah, labor and delivery floors are busy enough in Canada. That spot will get filled. Don't you worry.
For sure. For sure.
So listen, Sid, somebody comes in, they're in their own labor, let's say, right?
Yeah.
And we know that we are buckling in for a trial of labor after cesarean section. Walk me through from the nursing standpoint and the really hands-on care perspective. What does that look like for somebody for the most part?
Yeah. So as we've discussed in this episode, because those risks of uterine rupture are there, you are at a slightly higher risk, or you're deemed a slightly higher risk patient. simply because you've had a C-section before. So because of that, we have certain protocols that we've put in place. And most of the time, it's as simple as always being on continuous fetal monitoring. So unfortunately, we will have to have you on the monitors pretty much your entire labor. I mean, we can take you off here and there if you need to go to the washroom and stuff like that. But I like to have my patients on continuous fetal monitoring, and that is as per protocols at the hospital. So that's a big one. I think a lot of people associate continuous fetal monitoring with oxytocin or Pitocin drips, because that's another time that we have to have continuous fetal monitoring. But also, if you've had a previous C-section, we want to be keeping a close eye on baby and making sure that everything's good, because ultimately they can alarm us of things that might be going wrong. So we want to be aware of that, right?
One of the first signs of rupture may be an abnormality in the fetal heart rate.
Yeah.
And we want to be able to move forward with C-section as quickly as possible for you if that is happening. And so making sure that we have the earliest signs that could be occurring is usually recommended from the obstetrical teams.
Yeah. And as you said, like from a healthcare perspective and from the facility that you're delivering at, we like to also have an OR available too. So in case something does happen and we need to rush to the operating room, it's ready, it's available. So for us, we have it set to go, and that's not something you guys need to worry about, but that's something that we think about as we're caring for you in this situation, which might bring you guys some comfort to know as well. The other aspect that we like to consider when you are laboring with a previous C-section is getting an epidural. So that's actually something that we recommend for a lot of our patients, to get an epidural during labor. And it's not because, we're trying to sway you to not have a unmedicated delivery if that's something that you want. The reason being is because if an emergency does occur where we need to rush you to the operating room, it allows us to hopefully be able to top up the epidural and give it a little bit more medication so that you're completely numb before the C-section. Versus if you didn't have an epidural, we most likely would have to put you to sleep for surgery, which poses a lot of risks for both you and baby. So we like to avoid putting you to sleep for surgery if that's at all possible. And one of those ways is getting an epidural and having the epidural catheter inserted in your back.
In surgery. Yeah.
Yeah.
I think that's helpful context, Sid, because I find for a lot of the patients that we see that we take care of, it's really confusing sometimes why their providers, why their institutions might make recommendations that feel a little bit restrictive, right? Stuff like continuous monitoring, stuff like someone might recommend an epidural for some patients for a trial of labor after cesarean. And without explanation, without context as to why that recommendation may be made, I think it's really easy to feel like we're being over medicalized, like our bodies are being controlled in a way that doesn't feel right to us. And so, but I think also from the other side, when we do explain it, caveats are not always opposition, right? These recommendations don't necessarily mean that, number one, that anybody is going to refuse you care if you do not accept those, right?
Exactly.
And they're not also opposition to a trial of labor in general, right? In fact, again, in many institutions, we actually support, celebrate, and encourage patients through their trial of labor after cesarean. But rather, it's important to know why those recommendations might be made and how they could make a difference for someone's care as a whole. Epidural, as you mentioned, is a nice way for us to have access to anesthesia very quickly for an emergency. So truly, for anybody that we foresee an emergency cesarean delivery where time is of the essence, being something that is, that for which the likelihood of it happening is a little bit higher than just kind of the random occurrence. Something like an epidural is always something to consider, right? Because the truth is in an epiduralized delivery, for somebody who has good pain control, we can move them into the OR in under a minute, and many times, right? Doesn't take long to top up an epidural.
No.
Again, very few minutes, if any, and I can have a baby out in under a minute from the time of starting a C-section. So if we feel that your uterus is rupturing, yours or your baby's health is actively in danger, that's kind of the timeline we're working with. Whereas for a general anesthesia, because it carries with higher risks for mom, that can take longer, right? Because we need to administer that safely. And that doesn't mean that you have to have an epidural. But I think, again, like we're not doing a service to patients if we only encourage, what they want without also providing the additional context of what the consequences can be if things go wrong, right?
Exactly. Yeah.
And on that note, I think that kind of transitions well said into some of the like online discourse around trial of labor after cesarean, particularly in circumstances where we might feel that the risk is a little bit elevated. What sorts of things have you seen in that space?
Yeah. So kind of as we mentioned previously, a lot of talk about TOLAC is two separate extremes. It's often referred to as extremely dangerous and irresponsible or completely safe. Like you just have to trust birth and trust your body. And TOLAC is one of those topics where blanket statements are not going to work. And I think that applies to a lot of topics that we're going to talk about on the Push podcast, because the details really, really matter, right? Your medical history, your provider, your support system, the healthcare system, like that you're in. So where you are in the world, everything we've talked about in this episode, that really, really matters. And I think another aspect is that, sorry, I lost my train of thought.
No worries. I can jump in.
You can take on. Yeah,
I can jump in. I totally agree with you, Sydney. And not to get a little controversial here, but I do
please get controversial.
Listen, I find there's a lot of criticism towards OBGYNs in particular, but also labor and delivery nurses with respect to like our own encouragement or discouragement of people in contexts like trial of labor after multiple cesarean sections, like trial of labor after cesarean without fetal monitoring, like trial of labor after cesarean at home, for instance. And I think that there's a lot of like criticism for our lack of encouragement, I guess, in that area. And to that, I would say, like, listen, fair in many ways, right? Like, we are biased by our knowledge and by our experience within like a highly medicalized birthing system. However, what I would also say is that our bias comes from, at least in the vast majority of cases that I have experienced with my colleagues, with the people I'm fortunate enough to count as friends amongst providers, our bias comes from experience.
Yeah.
Right? Like when your center does 3, 4, 5, 6,000 deliveries a year, and you may do a dozen, 2 dozen deliveries even in a 24-hour shift, you are going to see uterine ruptures from trial of labor after cesareans. I have seen uterine ruptures after trial of labor after cesareans.
Yeah.
And I think that experience of like what the catastrophe looks like makes us feel, rightly so, that we have a responsibility to ensure that people really appreciate the weight of the worst case scenario.
Yeah.
Not because we want to scare people, right?
No.
But because, again, we're not doing anyone a service if we sugarcoat the experience as like always positive. Because we unfortunately know that no amount of perfect care can always avoid an emergency situation. Sometimes it's the patients that you least expected that have the emergency situation where we're having to move so quickly to save a baby's life, to save a parent's life. And again, like we like acutely feel the weight of that. And so I think number one,
and some creators online don't experience or manage those complications, right?
That's the thing. Yeah,
and then they have these strong opinions, but I think it's, that's why you have to tread carefully with what you see and read online, right?
Yeah.
Because there's also a lot of success stories online, but there's not as much of the scary stuff that we've seen, because no one wants to talk about that, right? You're going to talk about the successful stories, and the algorithm is going to reward those, right? So Yeah,
And again,
it's a hard one, but it's
not
important
meant
to
to scare
mention.
people. Again, the
No.
overwhelming likelihood, especially with an uncomplicated, good candidate for a TOLAC, is that they're going to have a vaginal delivery, and we're all going to be so happy and celebrate with them.
Yeah.
But I think, again, like, no amount of ideology about like your body is meant to do this, which you and I have unpacked in other episodes, where for you new listeners, it's not that I want to take away the sense of like celebration and awe about how incredible our bodies are that they're able to do this.
Yes.
But I really bristle at that framing, because I have taken care of so many incredible parents whose bodies were not listening to that ideology.
Yeah.
Right.
Yep.
And it is nothing that they did wrong. If your body is meant to do this, can sometimes like take away empowerment from somebody whose body didn't want to do it in that context, or couldn't do it in that context. And they're no less a parent, no less have had done no less of a delivery for having, needed things like interventions. And so like, I think no amount of ideology like is comparable to preparedness.
Exactly.
Right?
And just making sure everything's
TOLAC,
Sorry, I was just going to say that the information is grounded in accurate information, and the things, the confidence and the empowerment that you're like, it needs to be grounded with accurate information. That's
this
the
is the thing,
right?
If you decide that you'd like to do a trial of labor after cesarean after 2 C-sections, 3 C-sections, whatever it is, right? You are an autonomous human being, and you are completely within your right to choose that for yourself. But you are owed accurate information about what the risks would be, what an emergency looks like in that context, and how we might mitigate that risk, right? Because ultimately, like intervention, quote unquote, in that area in the form of things like fetal monitoring, epidurals, that kind of thing, is really with the intention of risk mitigation.
Exactly.
To try and like say, okay, if we're dealing with like a 9% risk of rupture in somebody with a classical cesarean section history, right? How can we chip that down a little bit, right?
Exactly.
Like, how can we chip that 9 down to like a smaller number to try and prevent this outcome that nobody wants to have happen?
And listen, guys, we know data and numbers and all that stuff. It's boring. It's not as compelling as the videos you see online. We understand that. But at the end of the day, like the data isn't going to lie. And also your experience as a provider and your provider that you're talking to, they're going to be able to tell you ultimately what, or recommend to you what they would suggest is best for you. And then ultimately you can take all that information and make your own decision.
And providers are not without bias themselves, right? Like we'll be the last, I'll be the last person to suggest that. I certainly have like moments after every like scary delivery I have where like I feel like my nerves are on a trigger. And so you're more than welcome, like advocate for yourself, ask for a second opinion, right? Like if something doesn't feel right to you, like ask why that's being recommended, and you have a right to that information too. Right. As with so much in medicine, like this whole dichotomy isn't really like either or, right? It's not like your body sucks at labor or rather like all certainly it's not your body sucks at labor. What I'm trying to say is it's not like, oh, like every TOLAC is so dangerous, or, the only way to have a baby naturally is a vaginal, like the only good way to have a delivery is a vaginal delivery. It's always somewhere in the middle. It's always an and getting that information, I think, and having these conversations in an honest way is how we get there.
Exactly.
The other thing I'll say as well is that, and not to like, I promise I'll transition to a more positive note, because the last thing I want is to like scare people with this discussion. But I will say, like it having walked the road of like a very difficult delivery with very difficult outcomes with more patients than I would like to over the years working in like a high volume centers. It doesn't matter if the risk was 9% or 1% or 0.5% or 0.2% when it happens to you.
Yeah.
And that's just kind of like the shitty truth, right? Like,
it is.
If it happens to you, if you're the one, it doesn't matter whether it's 100 or 1,000 or 10,000 because it's happening to you in your life. But the flip side that I will say, as we're talking about numbers and percentages and things like that, is that there is good evidence to show first of all, that like satisfaction is high after a trial of labor after cesarean. Now, obviously, satisfaction is higher if you do have a VBAC. So if your trial of labor after cesarean ends in a vaginal delivery, I mean, kind of intuitively, in many
you're
cases,
going to be happy
those
about
patients are going to feel, happier with the process. But I think
there's a sense of happiness and joy when they've tried, right?
Well, this is
sorry, not to jump in. I'm just
no. There's good evidence to show. There's a great study that looked at satisfaction rates, even amongst women who did not end up with a vaginal delivery as the conclusion of their TOLAC, and they found that 92% of those women still were happy that they tried. Right?
Oh, interesting. Yeah,
and I think that can't be discounted. That the opportunity to attempt a TOLAC holds value for many women. In fact, most women in this study, independent of what the delivery mode ultimately was. And again, and the study also showed that women who are engaged in, and patients who are engaged in formal TOLAC counseling programs, right? So formalized structured programs where we're able to have the space and time to talk about all of these things, who were then able to have a high level of understanding about risks and benefits. They also felt very confident and satisfied in the process, irrespective of the outcome. Yeah. And so I think that kind of circles back to the in many ways, being able to be informed, having the opportunity to ask and answer questions and choose a path that feels right to you is the ultimate most important thing.
Yeah. And I think that, Megan, that is a fantastic way to honestly wrap up this episode. No, seriously, because it's, always advocate for yourself. And, hopefully, listening to this episode is giving you ways that you feel like you can. And like you just said, you're okay. You're allowed to get second opinions, or you're allowed to explore your options. In fact, we encourage you to explore your options so that you can make a more informed decision, because, I think it's important to not pretend that the risk doesn't exist, because it does, right? And we've seen it. I think it's important to acknowledge that it's there, but then realize what decision you want to make, or what decision you are willing to accept with those risks, right? So, and that's the best way you can do it. So I think, is there any last thoughts you have for our listeners in terms of TOLACs and VBACs and everything we've talked about today in this episode?
Yeah, absolutely. I mean, and we've talked about all the individual components. We've talked about how nuanced it is. We've talked about some of the data and some of the statistics and what these risks, what do these risks mean in numbers? But at the end of the day, trial of labor after cesarean section is a valid evidence support option for many people who are looking to deliver their baby. It is not risk-free. Repeat elective C-section is also a valid evidence-supported option that is chosen and right for many people, right?
Exactly.
That is also not risk-free. Yeah. And having, again, that deep level of understanding about what these risks are, what they mean to you, and how they can be applied to your individual case, I think is really the underline to all of this at the end of the day.
Exactly.
And no one should feel sold a particular narrative in either direction. Right?
No.
Because everyone's case, everyone's history, everyone's family is so unique and individual.
Exactly. Well, everyone, if you have had a successful VBAC, if you had a TOLAC that ended in a C-section, if you had an emergency C-section and you're not sure what to do with your next ones, tell us your stories. We love to hear them. Ask your questions. So follow us on Instagram and TikTok at the.push.podcast. And make sure you guys also leave us a review on Spotify and Apple Podcasts. We would love it. We love seeing your reviews. It warms our hearts truly to continue doing this and hopping on this adventure with you. So I think that's
Thank
everything
you so
for
much
this
for
episode.
coming along. And listen, stick around for season 2 of the Push podcast. We have so many fun episodes, so many great topics to talk to you guys about this season. So many great special guests for our guest episodes, including many faces that I think you will recognize if you are internet people, as Sydney and I are.
For sure.
And we cannot wait to continue this journey with you guys. It has been such a privilege. We were so blown away by the response and the following from season 1. And we are so excited to continue to grow and share with you in season 2.
Yeah. All right. Bye,
Alrighty.
everyone.